hang on.
Yeah. Dr. Sushant is an alumni of All India Institute of Medical Sciences, New Delhi. He was a research officer there and has done his ULA certified course and written a chapter in API textbook of medicine. He's a rheumatologist at Dadar in Ruma Derma Clinic, Quest Clinic, Goregaon. He's a medical educator, director, Quest Medical Academy, training medical students for more than 11 years. He's a TEDx speaker. Charge and Care Paradox of Healthcare was his talk. Trustee, Ramdayani Health Foundation, Prerna Prakalp, Value-Based Healthcare Projects. So, Smriti, you've joined? Yeah, you're muted. You're muted, yeah. Yeah, Dr. Smriti Ramteke is a renowned rheumatologist at Nagpur. So, the student today is Dr. Ankita Dewangan. So, she will be presenting her case. Yeah, and I also welcome some senior rheumatologists are there today, Dr. Arun Kedia, Dr. Anita Balsoraj, Dr. Sanket Shah. I welcome all of you to this session. Yeah, so, yeah, Smriti, you can hear us, no?
Yes, ma'am.
Yeah,
Yes.
okay, over to you, Smriti and Sushant. And Ankita, you can start your presentation. Yeah.
Thank you, ma'am.
Yeah.
Good morning, respected teachers, seniors. Today, I'll be presenting a case in MRA student-teacher interface platform. Myself, Dr. Ankita Dewangan, and I am a DRNB first-year resident at Department of Rheumatology at TNMC and Nair Hospital. Shall I start, ma'am?
Yes, please start. Yeah.
27-year-old married lady, BCom graduated, who is a homemaker by profession, resident of Nasik, Maharashtra. She came to us with a chief complaint of episodic bluish discoloration of fingers and skin tightening since 1.5 years, regurgitation of food, and exertional shortness of breath since 1 year. Patient was apparently all right 1.5 years back. Then she started complaining of episodic bluish discoloration of bilateral fingertips of hand during the exposure into the cold temperature and water. And at that time, she was able to notice the whitish discoloration of fingertips, and which gets changed after sometimes into a bluish color. And these symptoms were associated with mild pain in the fingertips, and the symptoms tend to relieve after massaging or warming the fingertips. So the symptoms are suggestive of Raynauds phenomenon. Simultaneously, patient also complained of skin tightening over the fingers of bilateral hand since 1.5 years in the form of inability to make a complete fist without any significant pain. 6 months later, patient also had a symptom of multiple episodes of regurgitation of food particles since last 1 year, which used to occur after 15 to 30 minutes of a heavy meal. And initially, it used to occur during the night time, especially while during lying down for sleeping, and it tends to relieve with taking upright posture or taking antacids or post PPIs. And this symptom is associated with burning sensation over her mid chest and anterior part of her neck. Since 1 year, patient also complained of exertional shortness of breath, which was insidious in onset and gradually progressive. Initially, it used to occur only during the moderate activities such as climbing stair or walking rapidly on the ground. Then the symptoms in the next 3 to 4 months progressed in such a way that she was breathlessness even on walking at her own pace. And for the last 1 to 2 months, she was breathlessness even on walking for about 100 to 150 meters. She denied any history of PND, paroxysmal nocturnal dyspnea, or any anginal type of chest pain. The symptom was associated with generalized body pain, generalized body swelling, which was insidious and also gradually progressive. Initially, it started from the bilateral foot region, followed by gradual abdominal distension, and followed by facial puffiness, periorbital swelling, and followed by all over the body. These symptoms was occurring since the last 1 year, and it was associated with decreased urine output. Coming into the negative.
Excuse me.
Yes.
Ankita, did the patient have any cough along with the breathlessness?
No, ma'am, there was no cough, ma'am, that I have included in negative history, ma'am.
Okay, there was no cough with breathlessness.
No, ma'am. No, ma'am. Ma'am, continue. Should I continue, ma'am?
Maybe you can go a bit slow. A bit slow.
She does not have any complaint of hair loss, recurrent oral ulcer, photosensitive rash, fine photosensitivity, or any vasculitic rash. There was no history of any skin tightening beyond knuckles, face, or trunk. No history of any significant joint pain or swelling. There is no history of any obvious muscle weakness. No history. She denied any history of dry mouth, dry eye, intermittent claudication, or digital ischemia. She does not have any complaint
How
of.
did you ask the history of dry eyes? What
Ma'am,
was the question?
ma'am, grating type of sensation, like something has come into the coming into her eyes. Uh, have to uh, have to blink her eyes more frequently.
Okay. Is there an easier way to ask for it?
Foreign body sensation, ma'am.
You can just you can just ask them whether there is some whenever they want to cry, do they have any tears?
Tears, yes, ma'am. Less tears formation.
Yeah.
There was no history of any frothy urine, hematuria, no history of any dry cough, hemoptysis, or any other respiratory complaint. There was no history of any diarrhea, bloating sensation, constipation, history of black stool, or jaundice. Coming into the past history, she had a significant medical history of Graves' disease, which was diagnosed 4 years back as she was having the symptoms of gradual unintentional weight loss with preserved appetite. She lost her weight from 65 kg to 48 kg, and her symptoms were also associated with more of irritability, fever, palpitation, decreased sleep at night, and exophthalmos. For that, she was treated from the outside physician, and she was given a carbimazole tablets along with propanol and calcium vitamin D supplements. And then after 4 to 5 months, her symptoms were improved, and she was being followed up for the last 4 years from the same physician. Her medications were tapered, and she was on only 10 milligram of carbimazole uh, up till now. And after that she achieved the euthyroid state also, and she also does not have any history of chronic illness like diabetes, mellitus, hypertension, chronic kidney disease, or any other chronic illness in the past. Family history, there was no history of similar complaint in the family, and other family history was not contributory. Personal history, she was married. She consumes mixed diet, and her sleep cycle was decreased in the night times where she was having a frequent regurgitation of food particles. And her urine output was initially it was decreased during while she was having this generalized body swelling, and she denied any history of addiction to tobacco, alcohol, or any cigarette smoking. Coming into the menstrual or obstetric history, she attended menarche at the age of 13-year-old when she was 13-year-old, and her last menstrual period was 15th of January. Her past and present menstrual cycle were normal, and she had only one live girl child of 6 years of age.
Any history of abortions in the
No, ma'am,
past?
there was no history of any abortion.
Okay. Is she working or she's not working?
No, ma'am, she is not working. She is homemaker, ma'am, and sometimes she used to help her husband. Her husband used to work in some shoes company, and she used to wash clothes. And while washing clothes during the winter season only, she noticed that Raynaud's symptom.
Okay.
Then treatment history, as she was developing this exertional shortness of breath and generalized body swelling, her physician referred her to nearby cardiologist, where she was being told that her right side pressure were increased, and for that she was being advised to take tadalafil and ambrisentan tablets and along with the diuretics. Because of this grade 4 breathlessness and generalized body swelling, she got multiple admission almost 3 to 4 times since last 7 months. And every time she used to put on vasopressor support along with the diuretics. And the last time she was admitted on 29th of Jan in the GMC Nasik, and from where she was being referred to our hospital for further management. Though she went to the cardiologist, ma'am, but there was she did not evaluate it in the line of that increased pressure. Probably she was being told that she is having a pulmonary arterial hypertension.
Okay, so there was no reports with her.
Ma'am, she had only 2D echo report and CT pulmonary angiography. So the summary of my case is 27-year-old married lady with uneventful obstetric history, known case of Graves' disease, which is coming into the euthyroid state, having the symptoms of 1.5 years of Raynauds phenomenon, along with a skin thickening, which is limited up to the knuckles, that is metacarpophalangeal joint, with frequent episodes of GERD, GERD, and 1 year of progressive dyspnea with generalized anasarca, probably suggesting decompensated heart failure.
Dr. Ankita,
Yes, sir.
one question at this point, maybe you're going to say this ahead, but
Yes.
this anasarca, what do you attribute this to based on, if we forget the reports that you told us, some past in history, medical history where she was hospitalized, we don't have those details yet.
Yes,
Are you
sir.
attributing this to heart failure? Do you think we are dealing with pulmonary hypertension only, as in not the left side only, right-sided heart failure? Is this renal?
Sir, so based on the history, as she was developing this anasarca from a bilateral lower limb, sir, and then it expands, then it progressed into the abdomen, then the facial involvement. So the pattern of involvement of generalized anasarca is more of a cardiac part. So, and this was associated with progressive dyspnea also. So maybe patient can have some lung issues. Because of that, she might be developing increased pressure over the right side of her heart. And yes, sir. This.
Okay, so if I rephrase this question, let's say we find pulmonary hypertension in her case. Will you attribute this as a secondary pulmonary hypertension, which means secondary to either a pulmonary parenchymal cause like ILD or left-sided heart disease like heart failure? Or
Yes.
will you consider this as a primary pulmonary hypertension if you find pulmonary hypertension in this case?
Yes. So at this point, sir, for left-sided heart disease, secondary to left-sided heart disease, she denied any history of PND or any anginal symptoms, sir, which could relate her left heart failure symptoms. And also,
Right.
sir, there was no history of any dry cough,
Right.
long progressive dry cough. So probably those two are not the cause of this generalized anasarca.
So we are thinking of primary pulmonary hypertension if
Yes.
we find it. Right.
Yes.
So then I'm confused. Why is there a decompensated heart failure as your diagnosis? In summary.
Sir, because when she came to us, sir, she was decompensated to a level that she was not able to leave her house also. This was a grade 4 dyspnea, and because of that only she was admitted to us. Otherwise, she was just taking diuretics tablets from the cardiologist for grade 2 or grade 3 dyspnea along with the swelling. So,
Okay. Okay, fine.
So is it a biventricular heart failure?
ma'am, more of ma'am, when she came to us, she was grade 4 dyspnea. So maybe because maybe the right-sided symptoms can progress to the left-sided heart failure. That time she might be having a biventricular failure, ma'am, at this point of time.
See, if you have severe pulmonary hypertension, can that itself explain oral symptoms? Do you need the left ventricle to have failed? I'm talking only on history that you have presented by now. There isn't much to say of the left side, right? So is it possible that we are dealing only with pulmonary hypertension here? Severe pulmonary hypertension, can that explain the anasarca and the dyspnea that she's experiencing?
Yes, sir.
Okay. Fine, please go ahead.
So based on the summary of my case, I kept as a differential diagnosis first, CREST syndrome, and in my patient, she was having this Raynauds phenomenon with esophageal dysfunction in the form of gastroesophageal reflux disease with sclerodactyly, with organ involvement, probably pulmonary atrial hypertension with or without interstitial lung disease. And I kept my second differential diagnosis as multisystem connective tissue disease, mixed connective tissue disease.
What about the thyroid? You have not mentioned in your final diagnosis.
Yes, ma'am, with known case of Graves' disease, ma'am.
What is the association of thyroid disorder,
Yes, ma'am.
scleroderma?
Thyroid disorders are commonly associated with more of this limited cutaneous systemic sclerosis, ma'am. More of hypothyroid as Hashimoto thyroiditis as compared to Graves' disease, but Graves' disease do occur in almost 3% of the cases, and 10 to 15% of the cases Hashimoto is associated with limited cutaneous systemic sclerosis, ma'am. So this is quite...
autoimmune thyroiditis, thyroid papillary carcinoma is also associated, especially you have a lot of weight loss, etc.
Yes,
So I think
ma'am.
you should add that in your final this.
So is hypothyroidism more common in patients with scleroderma as compared to the general population?
Ma'am, I don't know.
Yeah, it is.
Yeah.
You can read about it.
Okay, ma'am. Should I go ahead, ma'am?
After this, what you're going to present the examination findings? No?
Yes, ma'am.
Yeah.
Yes,
Dr. Sushant, you want to ask anything else so far?
No, ma'am.
Yeah, go ahead. Yeah.
She came to our hospital. She was being referred from Government Medical College Nasik from our hospital when she was having and with all this NORAD and diuretic support. So I examined the patient on day 3 of her diuresis in our setting. She was conscious, oriented to time, place, and person. Her height is 155 centimeter with weight of 70 kg. BMI was 29.13 kg per square meter, and her vitals were she was afebrile, maintaining 88% saturation on room air, and she was on oxygen support, maintaining 95% saturation. Her pulse rate was 96 beats per minute, regular rhythm. She was with normal volume, and her peripheral pulses were feeble. Her blood pressure was 90 by 90 systolic and diastolic 50 millimeter of mercury on right arm supine position with NORAD support, and her respiratory rate were 16 breaths per minute. On general examination, pallor was present, and she has all over the pitting type of edema, including the pedal edema, abdominal parietal edema, periorbital edema, and the facial puffiness. She has exophthalmos as she was having a Graves' disease. Her peripheral extremities were cool. JVP was elevated up to 6 centimeter from sternal angle, upper column, and icterus clubbing and lymphadenopathy was absent. Skin thickening was present up to metacarpophalangeal joints in bilateral hands. There was no skin tightening over the face, trunk, or beyond the knuckles. There was no telangiectasia over the hand, mucus, or face. She has an adequate mouth opening, and there was no pulp atrophy, digital pits, or scar, or any gangrene.
One question over here.
Yes.
You're saying that the patient had exophthalmos and
Yes.
she still did not have any gritty sensation in her eyes. Very often patients have both.
Yes, sir. Actually, sir, she told ki because she was being treated for 4 years, so she was using some topical eye drops, sir, for that. And because since last 2 years, her exophthalmos like somewhat it went down, sir. And she did
So
not say yes,
usually
sir.
in graves, that's the most difficult part to treat. The
Yes,
exophthalmos doesn't respond very well to most
yes,
of our drugs. Uh, and there is a possibility that then the patient is not complaining of dryness because she's probably taking a lubricant eye drop.
yes, sir. She
So
was taking
that
some
was one of the
topical.
questions which was asked to so whether the patient has dryness of eyes.
Yes,
So
sir.
we could have mentioned it over there that there is possibility that she is having dryness, which we are
Dryness.
kind of not seeing right now. Another
Yes.
maybe a parallel question, JVP, were there any specific waveforms that you saw, or do you expect to see something here?
Yes, CV waves should be prominent, sir, if we are
Hmm.
suspecting the right heart failure. Uh, those waves were CV waves, might be, sir, which I was able to see.
Okay, please go.
And which were the places where you looked for telangiectasia?
Ma'am, telangiectasia, we can look at the fingers, ma'am, palms
Mhm.
and soles, and the face, and in the mucosal region also, ma'am, oral cavity.
Correct. Correct. Okay.
Coming into the systemic examination, her CNS was central nervous system was normal. On respiratory system examination, she was having a bilateral basal coarse crepitations, inspiratory crepitations, and on per abdominal examination, abdomen was diffusely distended with fullness over the flank. Along with the abdominal wall pitting edema, and there was a fluid thrill present. And I did a detailed CVS examination at this point of time. On inspection, trachea was midline, skin over the chest. There was no scar, sinus, or there was no venous prominence or precordial bulge. Apical impulse was present over the fifth intercostal space, lateral to midclavicular line. Pulsation was present at left second intercostal space. And on palpation, I confirmed the inspectory finding. Apical impulse was present over the fifth intercostal space, 1 centimeter lateral to mid-clavicular line, which is normal in character. Tricuspid area, there was a systolic thrill, and there was a P2 palpable over the pulmonary area. On auscultation, S1 heard normally, and there was a loud P2, and softer blowing pansystolic murmur was there in tricuspid area, which increased in leg raising or inspiration. So I came to the final diagnosis of 27-year-old lady, known case of Graves' disease, with a history of 1.5 years of Raynauds phenomenon with sclerodactyly, with symptoms of gastroesophageal reflux disease, along with a probably right side heart failure, most probably secondary to pulmonary arterial hypertension. And based on this, I kept my differential diagnosis as same, sir. CREST syndrome with organ involvement with known case of Graves' disease or mixed connective tissue disorders.
So based on your examination, does the patient have ascites?
Yes, sir. Fluid thrill was present, sir.
Right, and there are bilateral crepitations as well.
Yes,
Packles
sir.
are there.
Yes,
So
sir.
how do you explain those two? I mean, which part of your diagnosis explains that?
Sir, because of the right-sided heart failure, patient can have uh, uh, secondary left-sided failure, sir, uh, in the decompensation.
Unlikely.
Yes,
Unlikely. It's the
very
other way around, no? It's the right
or
left-sided
patient.
failure which will cause the right side to fail.
Yes.
Unlikely to go other way around. So why are there crackles bilaterally?
So patient might have symptoms of ILD, sir.
Yeah, so I think in the differentials you should consider ILD, because if you are considering then you will advise an HRCT, right?
Yes.
Yeah. So at this point, I think ILD is not ruled out. We
Yes,
still
sir.
have crackers to explain. And is there a possibility we are dealing with some renal component here? Because she's having such gross anasarca. Is pulmonary hypertension sufficient to explain everything? It's possible, of course. It's very severe pulmonary hypertension. But would you consider a renal possibility here?
Yes, sir. We should consider, sir, because this, if we are keeping this diagnosis, then we should think of this renal issue, sir.
Like
But
what?
so maybe AKI, sir, because of having the low cardiac output, or scleroderma renal crisis.
Okay. Scleroderma renal crisis in your patient, what goes in favor of it? What goes against it?
So against is, sir, patient should have a accelerated hypertension
Right.
with, but in my patient, she was already on NORAD support.
And
So
the
with
duration is way long, no? Your patient has
yes,
been ill for a long time. You won't
yes,
expect the patient to be so long, such a long history of scleroderma renal crisis.
renal crisis.
Is there a possibility patient is having significant proteinuria and that's contributing to the anasarca and everything that you're seeing?
Yes, sir, it can be possible.
Okay, fine.
In the general examination, did you see for the oral cavity and the gums and teeth? Did you comment about it?
Yes, yes, ma'am. There was she has an adequate mouth opening, and her oral, there was no any gum atrophy or uh, periodontitis, ma'am.
So
Her
what are the
oral hygiene
complications
was
which
good,
you
ma'am.
expect in this patient? What are the problems which you can have in the oral cavity?
Ma'am, first of all, because of the dry mouth, a patient can have a frequent infections, or a patient can have a periodontitis, gum recession, loosening of teeth, or because of inability to open her mouth can lead to poor oral hygiene, and itself can lead to candidiasis, oral candidiasis.
Okay, this gum atrophy, can you find in patients with scleroderma?
Yes, ma'am.
So you can move. So in this general examination,
Yes,
did
ma'am.
you mention about the, just that slide? If
Yeah.
you look at the hands carefully,
Yes, ma'am.
there's a difference in the left and the right hand. So
Yes, ma'am.
have you mentioned this? Does she have a joint involvement?
No, ma'am, she did not tell any joint pain or any swelling.
But if you look at it, then there's some darkening in the
Yes.
PIP joints, the middle and the ring finger, and it looks a bit bogey as compared to the left side. So she did not have anything, definitely.
No, ma'am.
What is the total duration of illness in this patient?
Ma'am, 1.5 year, ma'am.
What are the usual typical features of the fingers and the nails in scleroderma? Do you think she has those? Not taken a picture of the palms of the hands, but usually when they have a limited cutaneous scleroderma has more of pulmonary hypertension early onset.
Yes, ma'am. Digital pits or scar, ma'am, we can see in the tips, or signs of ischemia, ma'am.
So she doesn't
No, ma'am.
have any of those features, no?
No, ma'am.
Yeah. Okay. The nails are very classically involved. The nail bed that is not involved over here, no?
No, ma'am.
Doesn't.
What is the difference between primary and secondary Raynauds phenomenon?
Ma'am, primary Raynauds phenomenon used to occur more commonly in less than 20-year-old individuals, and it should be bilaterally symmetrical, involving both the hands, and it is usually a mild to moderate in intensity, with no history of with no signs of any digital ischemia, pitting or scars, and there was no abnormality in nail fold capillaroscopy, and ANA should be negative.
It's triphasic usually, no? And in this patient, it's asymmetrical Raynaud's or symmetrical?
Ma'am, like I asked, she told like both in both the hands she used to have the same symptoms, ma'am.
Same, but it's
Yeah.
biphasic, triphasic. There's no gangrene at all.
Biphasic. No, ma'am.
What are the cause? What is the cause of digital fits?
Ma'am, because of vascular ischemia, can lead to small ulcers over the digits because of intense repeated vasospasms. And because of those ulcers can lead to scars.
Okay.
It's a vasculopathy.
Vasculopathies.
Dr. Sushant, you want to ask any more questions?
No, ma'am.
You can go on to the investigations.
Coming into the investigation on hematological parameter, her hemoglobin was low with 9.8 gram per deciliter with MCV of 88, suggesting normocytic anemia. Peripheral blood picture shows normocytic normochromic RBCs with anisocytosis. LDH was raised with 567 units per liter and direct Coombs stress was positive. Her ESR was elevated with 40 millimeter at the end of first hour, and the thyroid profile was normal. Her chronic viral marker was non-reactive, and ABG shows normal pH with the normal PO2 and PCO2. On liver function test, her SGOT and SGPT levels were elevated with 263 and 242 unit per liter respectively, and total bilirubin was 4 with direct bilirubin 2.9 milligram per deciliter. Total protein and albumin, total protein was 6.5 and albumin is 2.8. On renal function test, it was normal. Creat was 0.8 and urea was 16, and electrolytes were also normal. On urine routine microscopy, there was no albumin or any RBC or WBC cast.
Did this patient have icterus? Sorry, I missed that part.
No,
Did she have icterus? On examination, had you mentioned this?
no, sir. She was not icteric, sir.
Bilirubin is 4.
Yes, sir. Ma'am.
Still being there. How much bilirubin you need to have demonstrable icterus?
Ma'am, more than 2, ma'am.
She didn't have interest.
No, ma'am, she didn't have.
What
Ma'am,
was
So how
the
do you? Sorry.
Sorry.
Go, ma'am.
Sorry.
Go ahead, ma'am.
any evidence of muscle involvement in this patient?
No, ma'am.
Did we do
She,
the CPK of this patient? CPK?
ma'am, CPK, ma'am, actually there was no history of any muscle weakness, so we did not do CPK, ma'am.
Okay.
So how would you explain the liver function test in light of whatever history we have heard? What are the possible explanations for this liver function? Of course, we can investigate more, but at this point, what are you thinking?
So maybe it can be because of ischemic, the congestive hepatitis part, sir. Because of the failing left heart failure, because can lead to increase venous backward pressure over the inferior vena cava and
So
the
cardiac
congestive
cirrhosis.
symptoms. Yes.
Cardiac cirrhosis. That's one.
Cardiac.
Anything else?
Patient can have an overlap of autoimmune hepatitis or primary biliary cirrhosis.
Right. Primary biliary cirrhosis or autoimmune hepatitis? I mean, which one are you thinking more? Of course, they can both overlap, come together as well, but which one are you thinking?
So autoimmune hepatitis.
Yeah, ALP is normal, no? So,
Because ALP is normal. Yes.
Primary biliary cirrhosis will not have so much of ascites and so.
yes.
So at this point, what do you think? This is only pure scleroderma or something more than that?
Ma'am, I was thinking of overlap, ma'am, because of this, but because she was having this rapidly progressive symptoms, and also her SGOT and SGPT along with TB is also elevated. So she
She
might
also
have
has low platelets and she has a positive Coombs test.
positive Coombs test also, yes, ma'am.
So
Though
what goes in favor of scleroderma here really, except for the fact that there's a history of skin tightening, which on examination you have said there is none. So mouth opening is normal, no telangiectasia. What goes in favor of scleroderma?
so Raynaud's,
Which could be in other conditions as well.
Yeah.
history of gastroesophageal reflux disease, which is
That has
Okay.
multiple causes.
So could this be just lupus?
yes, sir.
No
It can.
scleroderma over here.
Yes.
So after the hand picture, and I was thinking the same. Madam also pointed out there is a possibility that there is synovitis there. Those PIP joints were discolored and probably swollen as well. So you should probably reconsider your differentials here. I mean, in the order, scleroderma still remains on the charts, but I think doesn't remain as the first possibility now. The
Okay.
liver also is involved, so we are dealing with multi-system here.
Yes, sir.
ठीक. Please go ahead.
USG abdomen suggested hepatomegaly with moderate ascites. ECG showed normal sinus rhythm with right axis deviation. 2D echo suggested normal left ventricular ejection fraction of 60% with dilated right atrium and right ventricle. The size of right atrium was 64 millimeter with pulmonary atrial systolic pressure was 80 millimeter of mercury with IVC dilated. There was a severe TR, moderate PR, and concludes to severe pulmonary hypertension. This is the CT thorax, which showed the somewhat ground glass opacity in the basal areas, but not typical of NSAIP pattern, which is more likely having a subpleural sparing, and she has also this dilated esophagus with enlarged RA or RBC. CT pulmonary angiography suggested there was no evidence of any thrombus.
Any reason to ask for CT pulmonary angiography in this patient?
Sir, this actually we didn't do. It was done from outside while she was being treated from cardiologist. So he just want to rule out this chronic thromboembolic condition. So I think he did.
Okay.
The ANA by immunofluorescence assay was 4+ with speckled pattern. ANA blot was positive for Smith and RNP with RO 52 was positive. Her C3 and C4 levels were normals, were decreased.
What was the urine protein?
Ma'am, urine albumin was negative, ma'am.
Negative.
Yes, ma'am.
Quantitative test wasn't done, 24-hour or a spot protein creatine ratio. Was that ordered?
No, sir, it was not done.
I think we should add that because
Yes.
we are dealing with more than what meets the eye here. So probably we should screen more.
Yeah.
So first we try to stabilize the patient because she was having this low blood pressure with all over the generalized body swelling with vasopressor support along with the diuretics, and we start because of because we were suspecting more of mixed connective tissue disease, we advised her steroids.
We should not call it mixed connective tissue disease. Overlap would be a better
overlap.
So how, Ankita, what is the difference between overlap and mixed connective tissue disease? What is mixed connective tissue disease?
Mixed connective disease can have overlapping symptoms of SLE or systemic sclerosis or dermatomyositis, ma'am. And it has there should be a essential criteria positive of U1 RMP level. And overlap is overlapping features of other autoimmune disorders like maybe SLE or autoimmune hepatitis.
Yeah.
Hepatitis is not in that. But
Systemic sclerosis, SLE.
what did the ultrasound show? Abdomen?
Ma'am, hepatomegaly was there with moderate ascites.
Spleen, portal vein and all?
Ma'am,
Not commented.
not commented, ma'am, because she was having so much of ascites and she was on in ICU setup, ma'am. She was admitted in medicine ICU. She was quite unstable that point of time. And unfortunately, ma'am, actually this patient died at the day 7 of her admission. So we could not proceed with other investigations. We might have done so many things in this patient. But then suddenly she collapsed, ma'am, on day 7.
So how do we explain her hypotension? We are giving her vasopressors. How do we explain her hypotension? What kind of shock is this?
So this is more of so it can be because of her right heart were failing and it was not able to pump blood into the left part of her heart. So because of that, uh, she was not having adequate uh, output, sir, cardiac output. So
So in
because
such a patient, in this particular case, what was the lowest blood pressure that was ever recorded? She has been on inotropes even before she reached your hospital, right? So any records of what was the lowest blood pressure? Is she a case who requires vasopressor is really my question here. What was the
yes,
lowest blood pressure that was documented?
sir, at times, sir, her blood pressure was not recordable at all.
When she came to your hospital?
No, so when she came to our hospital, she was already on NORAD support, but when she was admitted in the previous hospitals, she was having this after giving a fluid challenge of 500 to 1 liter of fluid also, she was not able to gain blood pressure. So because of that, they have started there only.
So pulmonary hypertension alone, I'm not sure, but I don't think can cause a blood pressure to be not recordable.
Yeah.
There has to be some other
Yeah.
component then
Was
that
there
we're missing.
X-rays or something else apart from that?
Yes, ma'am.
Was there any other infective cause as associated with it? Nothing.
No, ma'am, she was not having any fever or burning, micturition or any cough.
So I think no, I would consider this possibility that these records need to be really looked into. Was she ever that hypotensive that she needed drugs, or is it that we started NORAD and never stopped it? No, that is not uncommon to happen. That someone thought it
Uh,
should be started and we never took it off. Because
no, yes.
pulmonary hypertension doesn't explain this. Sepsis
Yeah.
के आपने history में कुछ नहीं कहा है. There is no other obvious reason why her blood pressure should be low. So if it is just pulmonary hypertension, why inotropes? And then inotropes itself, are they inducing some arrhythmias or something in future? Because till this moment, whatever you have told me, I don't see why should this patient die in the next 7 days,
Yeah.
except the blood pressure part. So how do we explain the natural history of this patient?
So when I looked into her previous reports, when she was admitted almost 2 to 3 times in other hospitals, and that admission was indication was admission was the same only. She was having this because of the low blood pressure. She used to have a frequent syncopal attacks. So when she went to those hospitals and they found out that her blood pressure was low and she was given a fluid challenge, and after fluid challenge also she was not able to maintain BP. So that's why they kept on NORAD support, and they just kept on NORAD support with diuretics because of having an NSRCA, and there was nothing was done there apart from this
Was a thyroid function or cortisol done at this time?
Yes, ma'am. Cortisol was done, ma'am. It was also done from outside, and it was normal, ma'am. I saw that.
Thyroid function was okay at this time?
Thyroid function. Her recent thyroid levels were also normal.
What is hepatopulmonary syndrome? Because we never evaluated her for cirrhosis, actually, no?
Yes,
Yeah.
ma'am.
They have not mentioned anything about the liver architecture in the USG report. No?
Yes, no, ma'am.
You were
They
dealing.
just saw this congested hepatomegaly and some irregularity in the echo texture. So they were not able to appreciate whether it was because of cirrhosis, because there was some hepatomegaly because of maybe because of congestive symptoms.
Pulses are often weak in scleroderma, so I think we should wind up the case because they were next talk. Anything else from your side, Dr. Ankita?
Mhm.
Sushant, Dr. Smriti, maybe you can just wind up, give a feedback. Any more questions if you want to ask?
No, she presented it very well, and the patient itself was a dilemma, which
Yes, very
was
true.
unresolved. But she presented it very well.
A lot of things unanswered here.
Yeah.
Dr. Sushant?
Yes, ma'am, I agree. Well presented, Dr. Ankita.
It's a difficult case, I think.
Yeah.
Yes, yes, lot of. I think the history, we need more details, but probably what happened before she came to the hospital, that is missing.
Yes, yes. Okay, so thank you very much, Dr. Sushant, Dr. Smriti, for being here today on Sunday and sparing your time. Yeah, and
Thank you so
ma'am.
much. Thank you.
Dr. Ankita, you can stop sharing your screen.
Okay, ma'am. Thank you, ma'am.
Okay, well done. Okay, so Dr. Ranjan, you're there?
Yes, ma'am. Good morning.
Yeah.
Good
Hi,
morning,
good
everybody.
morning. Yeah,
Morning,
you
ma'am.
can start sharing your slides. Hi, how are you doing?
I'm fine, ma'am. How are you?
I'm okay, fine.
And
Thank
good
you.
morning to everybody there.
Yeah, so today we have a very special person from All India Institute of Medical Sciences who's very popular among the younger crowd also and amongst all the seniors also. So Dr. Ranjan Gupta is Associate Professor, Department of Rheumatology, All India Institute of Medical Sciences. His main areas of interest are lupus, lupus nephritis, and biomarker-related research, ANA immunofluorescence patterns, patient education. He has about 45 publications and 4 book chapters. He has got the Aplar Center for Excellence Exchange Fellowships in 2022, Young Rheumatology Oration by IRA in 2021, Shakuntala Amirchand Prize by ICMR in 2018, Best Original Paper Award, Basic Sciences, IROCON 2013, Vittal Rao Nath Gowda Best Annual Thesis Award by API 2012. He's the associate member of Autoantibody Standardization Committee of IUIS, executive committee member right now of IRA from 2023-2025. And recently he's been appointed as the Indian ambassador for Aplar Young Rheumatologists. So today, Dr. Ranjan is going to speak on a very important and interesting topic, the evidence-based management of antiphospholipid syndrome. So we have got a lot of attendance today for today's PG case and for the lecture. Over to you, Dr. Ranjan. Thank you for joining us today.
Thank you, ma'am. And I would like to thank MRA for considering me worthy of giving this lecture. And I'm really happy that I'm delivering this lecture to this August audience. And first of all, I would like to know if my slides are visible. The first slide is visible.
Yes, yes. The picture of your institution is visible. Yes.
Yeah.
Great.
So I would like to start with the simple introduction. We know APS is an acquired thrombotic disorder. And based on whether it is in association with connective tissue disease or not, we can classify it as a primary or secondary. Now, whatever be the case, the disease spectrum remains more or less the same, at least the manifestations and the serological characteristics. So we have got in APS, we have serological evidence of thrombophilia in the form of antibodies. We have otherwise in clinical manifestations, vascular morbidity or obstetric morbidity and or obstetric morbidity. And we also have extravascular, extra-obstetric manifestations, which could be in the form of hematological, renal, neurological, cutaneous manifestations. Now, for today's discussion, this would be the flow. I would briefly discuss about the recent classification criteria which has come up last year. and I would like to discuss what has changed and why it has changed. Then, since it is an evidence-based discussion, I would be only giving evidences about what primary thromboprophylaxis is, secondary thromboprophylaxis, why should we do certain things and why should we avoid certain things, what is obstetric APS and how do we manage that based on the evidence available, certain miscellaneous obstetric issues which we encounter so frequently in our OPDs when the ladies who are planning a conception or are pregnant, they come to us with so many questions in their questions in their mind. And then very briefly about catastrophic APS. So start with APS classification criteria were first given in 1999. Now, this classification criteria was very preliminary. For the first time it was given, they had included only core clinical features, which were vascular and obstetric features. Laboratory criteria at that time included only LAC and ACLA. It did not have beta-2 GP1 included at that time because it hadn't been described in that much detail. And at that time, the persistence was calculated at 6 weeks, unlike what we do today at 12 weeks. So these were preliminary classification criteria, but it had limitations, like it did not have non-criteria features. Beta-2 GP1 was not included and persistence was defined at 6 weeks. However, things evolved within a period of 5 years. Another set of classification criteria which were given and followed up till last year, when it was modified to certain extent. The clinical manifestations definitions remained the same, but laboratory criteria included beta-2 GP1 antibody, and it also defined persistence. The criteria became more strict and it made it 12 weeks so that you do not have any false positivity at 6 weeks that can be taken as a positive criteria. And last year we had new criteria coming up, and new criteria came where apart from the core clinical features, it has evolved further to include all the non-criteria manifestations, commonly thrombocytopenia and other things, which I'll be showing in a minute. And we also have the persistence was kept at 12 weeks. Now, for diagnosing, for classifying a patient as APS, earlier we just needed a lab and laboratory criteria. But here, the entry criterion itself is one lab and one clinical. That means any patient who has only one clinical and one lab criteria cannot be made into APS as it was being done till that time, till last year. Now the criteria has become even more strict. It has become even more specific. And if we see, we have got clinical domains which have become even more specific with macrovascular, microvascular manifestations. We have cardiac manifestations in the form of thickening and vegetation. And then we have got obstetric and hematological manifestation. Obstetric manifestations have been further subdivided. They have been made, even the details have been added. And then we have, for the first time coming into picture, the positivity for antibodies has been described into various severity, whether it is present at one point of time, persistent, or even their antibody levels, whether it is moderate or high titers. Similarly, a patient who has got APS may also have other features which could give rise to venous thrombosis, arterial thrombosis. So that also has been taken into account. And if patient already has a high risk profile, with that, if patient develops a thromboembolism, he would be given a lesser weightage because it could be attributed to the other the risk factors that the patient is carrying. Now it has become better. We have for the first time we have entry criterion. Stratification has been done in the form of for the risk factors, and we have the pregnancy morbidity has been redefined. We have non-criteria manifestations included. We have got a separation of IgM and IgG subtypes, and even their two levels have been described so that the criteria can become more specific. Now I'll come to the main topic, that was about the evidence what we are using, evidence that we have for usage in the clinic. So primary thromboprophylaxis, what is the definition of it? Primary thromboprophylaxis would be done in a patient who is at risk but has never had a thrombosis. So these are the patients who have clinically significant APS profile, which would mean they have already tested twice at a gap of 12 weeks, but they have never had thrombotic or obstetric morbidity. So what is the risk? Why should we actually give them prophylaxis? Are they, first of all, at higher risk? So studies have shown that if they do not have any underlying CTD like lupus, risk is just less than 1%. Whereas in the presence of other CTDs, as we see commonly, the risk increases from 1 to 5%. So in these patients, for the first study came in almost 2007 when aspirin was given to these patients in the form of a randomized trial. And to their surprise, giving aspirin did decrease the proportion of primary outcomes. That means patient having any thrombotic event, as well as secondary outcomes, which would mean having any TIAs as per their study. But this difference was not statistically significant. In they combined the primary and secondary outcomes, still there was a differentiation between aspirin and the placebo arm, but still it was not statistically different. However, as a part of the gut feeling, patients are still being given aspirin. Now I'll give you the evidence why this is still unsolved puzzle. So they have now we have a meta-analysis available of almost 11 studies, 1,200 patients, where people have been they have a risk prophylaxis, they have a risk profile for antiphospholipid antibodies, but have never had a thrombosis. And in these studies, they have tried to stratify patients based on three features. Basically, are they completely asymptomatic, or they have SLE without APS but just antibodies, or they have obstetric APS but never had thrombosis. In all these three, aspirin shows superiority over placebo. However, they did a further sub-analysis and they tried to divide their studies into retrospective studies and prospective studies. And to our surprise, to their surprise, prospective studies still do not show that aspirin is superior for preventing any thrombosis. That is why all the agencies, including EULAR, is conservative in their recommendations for giving aspirin. EULAR recommendations in 2019, they do not recommend it for everybody. They conditionally recommend that asymptomatic APL carriers who have high risk APL profile may be given low dose aspirin, not everybody. Similarly, lupus patients who do not have any thrombosis but have antibodies may be given. Similarly, in non-pregnant women with a history of obstetric APS only, it may be used. So what is this high risk profile that decides whether the patient has to get aspirin or not is basically any lupus anticoagulant positivity, any double or triple antibody positivity, or persistently high titers of APL antibodies is considered a high risk profile. Apart from this high-risk profile, aspirin is not recommended routinely for any patient who enters your OPD with a positive test for APL antibodies. Next, we come to the next wonder drug, that's hydroxychloroquine, whether it should be given to all the patients who have antiphospholipid antibodies, but not thrombosis. So it's again primary thrombosis prophylaxis. Patient has never had thrombosis, but has only antibodies. A trial was done in primary APS patients who had never had thrombosis, two arms, hydroxychloroquine versus standard of care or only standard of care. And their outcomes were thrombotic events, as well as they tried to see whether hydroxychloroquine can decrease the APL titers. So to their surprise here also, giving hydroxychloroquine did not make any difference in terms of thrombotic events. However, again to their surprise, it did decrease significantly the antibody titers for anti-cardiolipin IgG, anti-beta-2 GP1 IgG, and anti-beta-2 GP1 IgM. Anti-cardiolipin IgM did not decrease significantly in the two arms. However, in both the arms, it did decrease spontaneously over time significantly. But both the arms, otherwise there was no difference between the arms. So hydroxychloroquine also is not recommended for everybody. And EULAR 2019 guidelines are silent about it. That is why. Whatever we have little recommendations from 2012 16th International Congress, it only recommends conditionally in patients who have antiphospholipid positivity with an underlying CTD and especially SLE. Otherwise, any patient who has got these antibodies, comes to your OPD, has never had a thrombosis, hydroxychloroquine is not required. Hydroxychloroquine should not be given. You may consider giving aspirin based on his high or moderate risk of antibody profile, but hydroxychloroquine should not be given. Now we come to the third that we commonly use, is warfarin. Can low intensity anticoagulation maintaining an INR of up to 1.5, can that decrease thrombosis in these patients? So people have again done a trial. So it's a study population of lupus patients with antiphospholipid antibody or obstetric patients with antibodies, but both without thrombosis. That is why it is primary thromboprophylaxis. Low dose aspirin was given to 82, and the other arm, low dose aspirin with warfarin, was given in 84. Followed up for 5 years. And both the arms did not show any difference. On the contrary, who had received warfarin had significantly more number of bleeding episodes. And that is why warfarin has not been recommended by any of the agencies as routine thromboprophylaxis, primary thromboprophylaxis in patients who have antibody positivity with or without any underlying CTD. You may use hydroxychloroquine if patient has got a CTD. You may use aspirin if patient has got high risk antibody profile, but warfarin for low intensity anticoagulation should not use. So what do we have so far in primary thromboprophylaxis? EULAR recommends giving low dose aspirin in patients who have high risk profile, but as we do routinely in our clinics, we would also like to assess the patient whether he has got other associated risk factors like cardiovascular disease. If patient does not have, we can monitor, we can do away with only aspirin. But if patient has got other risk factors for cardiovascular disease, we may try using statin. Again, the evidence for statin is not much, it's not good, it's not so good. Then we have to assess the patient whether patient has got any autoimmune disease or connective tissue disease. If nothing is there, we continue to monitor only with aspirin. But if patient has got any underlying CTD, we may try using hydroxychloroquine. Come to secondary thromboprophylaxis. Now, secondary means patient has had a thrombosis, and now we are planning the patient for prophylaxis for preventing further thrombotic episodes. So in this, we know that we are currently maintaining these patients on moderate anticoagulation, moderate intensity anticoagulation of maintaining an INR between 2 to 3. But what is the evidence for maintaining these patients on high intensity anticoagulation? Is that of any, is it any better than moderate? So we have got two studies. One was published in NEJM, which addressed only this issue. They divided their patients into two arms. One was maintained between 2 to 3. The other patients had an INR maintained between 3 to 1. And to their surprise, hazard ratio was slightly higher, but it did not reach statistical significance. They tried to subdivide their patient based on arterial or venous thrombotic events, or patients with whether they had lupus or patient had lupus anticoagulant positivity, but they did not find any significance between high and moderate intensity anticoagulation. Similarly, in another study, when the patients were divided into two arms, they actually found more number of events in patients, thrombotic events, who had high intensity anticoagulation, though it was not statistically significant. And that is why it is not superior to moderate intensity anticoagulation and is not routinely recommended, irrespective of what vessel is involved, whether it is a vein or it is an artery. Now, what should be the duration of anticoagulation? Should we anticoagulate every patient for lifelong, considering that it has got so many risks? So what has been done so far is that people have again tried to do this study, which was way back in 1998, but this is the only evidence that is available. Now, these patients, please ignore this antibody profile, because this is an indirect evidence from a study where they were trying to look at the risk of repeat thrombosis based on antibody profile. But however, we are using this data to our benefit. When patient who had first thrombosis, they were anticoagulated only for 6 months, and we saw that the repeat thrombosis events were high. Percentages were 29 and 14%. Now, after first thrombosis, they divided these patients into two arms. Either they anticoagulated them for indefinite time, or for 6 months. Now, these patients who had already had first thrombosis, when anticoagulated later on, patients who were anticoagulated for only 6 months had more number of events as compared to patients who had been anticoagulated for indefinite time. And that is the evidence available for these for duration of anticoagulation. It said that if patient has had an unprovoked venous thrombosis, patient should be anticoagulated lifelong for indefinite time. However, in these patients who have had a provoking event, like they have had a malignancy, they had surgical major surgery, in these patients, expert opinion, as in the guidelines, it says that these patients may be treated as otherwise garden variety cases of DVT, and you may try to stop anticoagulation at 6 months. However, if patient has got high risk antibody profile or has got additional thrombotic risk factors like cardiovascular or CVD risk factors, in those cases, these patients also should be anticoagulated for lifetime. Now, secondary if patient you have anticoagulated and patient again develops thrombosis while being on anticoagulation, what can be done? We do not have any evidence. Again, it comes based on very small studies and expert opinion. And they say, first of all, we should ensure that patient is taking the medicine regularly. And then one of them can be done. We can add aspirin to moderate intensity anticoagulation, or we can increase the intensity of anticoagulation to 3 to 4, or we may transition the patient to low molecular weight heparin. Now, the buzzword in antiphospholipid syndrome, DOACs, the direct oral anticoagulants. So how good or bad they are. So before I speak about this in detail, I would just show you these 4 studies which have actually been proven to, the nail in the coffin of these drugs for APS. So these 3 studies, first 3 studies in 2016, 18, 19, published on rivaroxaban, having good number of patients, more than 100, good randomized trials, followed up for 569 days, 36 months, and you see the result. The study had to be, this did not reach inferiority, the first study. The second study had to be terminated prematurely because there were more thrombotic events in patients who were receiving rivaroxaban, and the other study also did not show any superiority of rivaroxaban. Another study on apixaban done in 2022 was again prematurely terminated because there were more thrombotic events in apixaban group. And following which there have been multiple meta-analysis to try to see whether they are actually beneficial. And this one meta-analysis published in 2022 included all these 4 studies and another study on dabigatran. You see the number of patients, good number of patients, and good number of patients with triple positivity. The problem, double or triple positivity that we commonly encounter in our OPDs, have looked at the efficacy and safety, and you look at this efficacy bars. The blue bars are for DOACs, and you see any thrombotic events, arterial thrombotic events, venous thrombotic events, strokes, or thrombosis in the triple positivity. All of them, warfarin is doing superiorly. We see safety, there are no major safety concerns, but then it gives a clear message that DOACs are not good as long as we are considering the efficacy of these drugs. Further, multiple meta-analyses have come looking at various aspects, which I'm just projecting in short here, which have included these 4 RCTs, multiple other RCTs, as well as cohort studies, retrospective and prospective cohorts. And you see, look at the thromboembolic events. They are almost the same in 2 groups. Look at venous thromboembolism and see this forest plot, and it is basically the same. Look at the arterial thromboembolic events, and this favors control. That means arterial thromboembolic events are likely to be more in DOACs. We look at major bleeding. As I told, there are no major safety concerns. It is similar. We look at all-cause mortality. That is also similar in the 2 groups. And if we look at the thromboembolic events in triple versus non-triple positivity, it again favors control group. That means DOACs are not good when we are dealing with patients who have triple positivity. Major bleeding in these 2 groups of triple or non-triple positivity, not very different. And then we have thromboembolic events. That is also similar. Arterial thromboembolic events, that is also similar. And then this is about individual DOACs actually. They're giving data for rivaroxaban, apixaban, and dabigatran separately. And you see rivaroxaban has done poorly as compared to the other 2, as I had shown in the first slide on this topic. And then you see the rivaroxaban about arterial thromboembolic event, it particularly does poorly. And then venous thromboembolic events are almost same for all the 3 drugs. Major bleedings were similar for all the 3. So if we have to, what are the recommendations? And this slide, probably this is one slide that, this is, if you want to carry home one message, then this is this, that across the indications, you have arterial thromboembolic events, you have triple positive, double positive, you have venous thromboembolic event, whether single or double positive or triple positive. Warfarin or other vitamin K antagonists are the first choice drug. We should never use any DOACs as first line drug. And this is across all the prevalent guidelines. You can see ESC, EULAR, British Society, the International Society for Hematology, all of them recommend vitamin K antagonists as the first choice. So when should we use DOACs? First of all, they are contraindicated when you have arterial thrombosis or any triple double positivity. However, they may be used when patient has got venous thromboembolism with non-triple positivity conditionally. And if patient has got some kind of hypersensitivity to warfarin, we may still try doing that. This is the only recommendation for DOAC. Arterial thrombosis. Now, what is the role of high intensity anticoagulation in arterial thrombosis? We saw that it was useless in venous. So arterial thrombosis, since it has got higher chances of recurrence, is it any useful here? Same study from NEGM that I had quoted for venous, we see that arterial thrombosis, though the patient numbers are lesser, but it did not find any significance. And in another study, high intensity anticoagulation as compared to conventional treatment did not show any difference. So again, it is not recommended, but yes, it is said that if there are chances of high intensity anticoagulation routinely, EULAR says that you may add low dose aspirin with vitamin K antagonists in arterial thrombosis, but no point in doing a higher intensity anticoagulation. Recurrent arterial thrombosis, in spite of anticoagulation, how do we deal that? Like we saw that we had three choices for venous embolism, venous thrombosis. The same is applicable here. We should counsel the patient first of all for drug adherence, and then either we can add aspirin, aim for a higher intensity anticoagulation, or transition to low molecular weight heparin. But again, there is little evidence. Now I'll come to obstetric APS. So obstetric APS management any asymptomatic APL carrier. So a lady who is pregnant but has got asymptomatic, who is otherwise asymptomatic for antiphospholipid syndrome, but she has got antibodies. So there are no direct studies assessing the efficacy of low-dose aspirin, but in high-risk pregnancies, otherwise there have been studies where they have tried to give low-dose aspirin and seen. In that particular study that I'm quoting from 2017 from NEGM, only 4 patients had APS. So actually we do not have any evidence, but whatever little we have, this is the thing. And we saw that aspirin actually improved the outcomes in these patients who had a poor pregnancy outcomes. So based on this, the recommendation is that by EULAR that consider aspirin in high risk APL profile. Even here, EULAR is not clear that we should give it to everybody who has got obstetric APS with APS, but without any thrombotic event. And in the 2020 ACR guidelines also conditionally recommend starting aspirin before the 16th week of pregnancy and continue it throughout pregnancy. Now, patient is pregnant, patient has got obstetric APS, but there's no history of any thrombosis in the past. So patient has got pure obstetric APS. The data here is also not very good, but whatever little we have is about these 6 RCTs. So 4 RCTs say that adding aspirin and heparin for these patients may be good, and the other 2 RCTs are against this. And if we see the data, which has basically a meta-analysis of these RCTs, it actually favors adding heparin to aspirin, and that is what the conventional practice is. So the patients who have a obstetric APS, with or without lupus, with APS, with prior fetal loss, you should add heparin with low-dose aspirin in these patients. Whether they have ever had any thrombosis or not, it doesn't matter. And same, because these patients, once they deliver a baby, they are at a higher risk during the first 6 weeks in the postpartum period. It is recommended by agencies like ACR and EULAR that we continue heparin and low-dose aspirin. And if the patient does not have any thrombotic event in the past, we can stop heparin at 6 weeks. You may at that time you may even stop low-dose aspirin. With thrombosis, what is the evidence? So risk of thrombosis is definitely paramount. Patient is pregnant, patient has had thrombosis. What should be the strategy, treating strategy? Because if the patient develops thrombosis during pregnancy, it will be even more detrimental. So the evidence again for this comes from some indirect studies. This was one study where they have had almost 100 to 110 patients. They have tried to subclassify their patients according to different risk profile. Patient had only thrombosis, patient had lupus alone, patient had triple antibody positivity, patient had thrombosis for lupus, or patient had thrombosis with triple antibody positivity. Now, this is the group where we are concerned. Patient has got antibodies, patient has got thrombosis, and patient becomes pregnant. Is there any point in giving prophylactic or therapeutic dose heparin? Patient has got thrombosis, so that is the usual practice. We do give therapeutic dose heparin. In this particular group alone, the authors saw that as you increase the dose of and the intensity of anticoagulation, you give only aspirin, you give prophylactic heparin with aspirin, you give therapeutic heparin with aspirin, the outcomes are consistently improving, which was statistically significant. And this is the only study quoted across the guidelines whereby they say that patient who has had thrombosis in the past and has obstetric APS, you should increase the intensity of anticoagulation to therapeutic with heparin. So both agencies say that you should give aspirin plus therapeutic dose of heparin in these patients. And similarly, in the postpartum period, since there is a higher chance of since there is higher chances thrombosis during the puerperium, you should continue this heparin and aspirin during that time also. And after 6 weeks, you should try to change it to warfarin. Now, some miscellaneous obstetric issues that we commonly encounter in our OPDs. First is giving steroids in the obstetric APS. Is it of any use? So there has been a trial where prednisolone, this is the study, basically they have tried to look at this is the meta-analysis. So patients, all of them received aspirin with low molecular weight heparin, and the meta-analysis was done based on the dose of steroids given to these patients. So low to medium dose of steroids in some studies, less than 20 milligram, and some studies where they had given higher dose of steroids to the regime of aspirin and heparin, and they looked at the pregnancy outcome. And you see in both these groups, there was actually no difference. So giving steroids was no good, no difference in abortion rates, no difference with respect to the dose of steroids in these. Further, what they found that rates of preeclampsia was almost 3 times higher in patients who received steroids, gestational diabetes almost 4 times higher. However, preterm births was not very different. So giving steroids is actually of no use, rather it is detrimental to the pregnancy. Similarly, there is a comparison. So this was another systematic review where they have compared the different prevalent regimes in pregnancy obstetric APS. What is the evidence and what is the best regime that you can use? So on the left side diagram, these are basically the regimes, like only aspirin, low molecular weight heparin alone, aspirin plus unfractionated heparin, aspirin plus low molecular weight heparin. And the thickness of the bar basically represents the number of studies or the quality and the strength of the evidence available between the two groups. So here, if you see this, like I'm comparing aspirin and aspirin plus low molecular weight heparin. So here I can find aspirin and low molecular weight heparin, and here I find only aspirin. So I compare these two, and I'll come to this box which shows that aspirin plus low molecular weight heparin has got 2.93. The odds of having a fruitful pregnancy would be almost 3 times. And here, if we see, this is the arm that has actually done consistently better as compared to aspirin plus prednisolone, IVIG alone, prednisolone alone, aspirin alone, or placebo. So standard regime that we have today, based on the strong evidence which is in favor of aspirin and low molecular weight heparin in pregnancies where patients have had poor pregnancy outcome in the presence of obstetric APS. Now, serum antiphospholipid antibody status. Does it have any effect on the IVF? Basically, can it affect the outcome of in vitro fertilization? So this is a meta-analysis of 6 studies. None of them had APS. They had only antibodies positive. They were going for IVF. Almost 3,000 patients. They have looked at the association of antiphospholipid antibodies on live birth rate, pregnancy rate, and miscarriage rates. And we look at the quality of studies, and we look at the antibodies that they have tested. So studies are a bit older, 1996 to 2018, but almost all types of antibodies have been covered. And we look at the studies of selection of unexposed cohort, or we look at the other outcome assessment. All the studies have got a good quality. They have had all the outcome measures recorded. And we see that pregnancy rates in the group, basically, they were not different. The patient had antibody positivity or patient did not have any antibody positivity. Live birth rates were also not different, and miscarriage rates were also not different. Basically, we can assure, this is to reassure the patient that having an antiphospholipid antibody, either single, double, or triple, is not going to affect the outcome of in vitro fertilization. So that is what we have the evidence in our hand when we are telling all these things to the patients. The next thing is about APS antibody status on pregnancy outcome. A normal pregnancy, patient did not have any APS. They are all asymptomatic antibody positive. A meta-analysis of 22 studies, almost 11,000 patients. They have tested the association of these antibody being positive or negative, association with fetal growth retardation, and they have also they have not looked at the subtypes, but they have looked at whether these antibodies being present asymptomatically can affect the outcome of pregnancy. And in their study, they have looked at the antiphospholipid antibodies. It did have some effect, though minute, but it did have statistically significant effect on pregnancy outcome for anti-cardiolipin antibodies, for anti-beta-2-GP1 antibodies, but to their surprise, lupus anticoagulant did not affect the pregnancy outcome in these patients. So that's what is the available evidence whether asymptomatic positivity of these antibodies can affect the pregnancy outcome. So in obstetric APS, we should basically, if patient is pregnant, we should decide whether the patient is asymptomatic APL carrier. EULAR says you can give high risk profile patients low dose aspirin if they are double or triple positive. ACR says give all of them uniformly at least aspirin. Go for obstetric APS. Patient has had pregnancy outcome. In those patients, low dose aspirin and prophylactic heparin should be given, and they should also be maintained on heparin in the puerperial period. However, if the patient is pregnant, obstetric APS, and has had thrombotic events, only changes you should treat them with hepatic heparin, and the same should continue in the puerperial period also. Now, briefly about CAPS, we all know what CAPS is and what the criteria is about this. Basically, the incidence is very low, and it is the most severe manifestation of antiphospholipid syndrome, where there is involvement of multiple organs almost simultaneously with histopathological evidence of small vessel occlusion. Guidelines, there are no guidelines. Basically, the CAPS registry, which has got almost 600 patients, the data comes from that. And on this, whatever little data we have across the agencies, the guidelines are almost the same. So I'm first quoting the EULAR 2019 guidelines. They say that these patients, when you suspect CAPS, should be started on a combination of steroid, heparin, and Plex or IVIG. You should use rituximab or eculizumab only if these turn out to be unsuccessful. Similarly, if you look at the guidelines of 2018 McMaster guidelines, they also say that first line therapy should be steroid, heparin, and Plex. 2020 16th International Congress also endorses these guidelines of 2018. So basically, we have got 3 agencies recommending a combination of steroid, heparin, IVIG, or Plex for all patients of CAPS. What they strongly not recommend is that rituximab is not the first line therapy, and that is what we should be. The message should be that rituximab is not the first line drug. You may use it once these things turn out to be unsuccessful and the disease turns to be refractory. The same is written here, basically anticoagulation, steroids, and IVIG. If clinical improvement is there, we can try tapering the drugs. If refractory disease is there, we go for other experimental therapy like rituximab, eculizumab, or cyclophosphamide. So take-home messages from my side would be, whenever we see a patient who has antiphospholipid antibodies or APS, we should first try to differentiate whether he has got APL, is an APL carrier, or he has APS. It could be vascular or obstetric or both. But the treatment would be decided based on, first of all, this particular character. Then the second thing should be, we should decide his risk profile. I have got a few patients who are 5 antibodies positive, and they don't have all the 5 antibodies positive, and they've not had any vascular event. So in those patients, we are just keeping them on aspirin, and we are not doing anything. So decide the high risk, whether the risk profile, and accordingly we should decide. And then we have to basically, the should be that individualized approach is required for thromboprophylaxis. We should have to assess whether the patient can have chances of bleeding. A patient who is 50 years old and has not had any thrombosis, patient is only antibody positive, I may actually not like to give him anything. Pregnancy with antiphospholipid or APS, we have to at least give aspirin and then plus minus heparin based on the condition. There is absolutely no evidence for high intensity anticoagulation, whether the thrombosis is venous or arterial. And there is absolutely no evidence for superiority of DOACs. It should never be used routinely and definitely never as first line therapy. So thank you very much, and I'll be happy to take the questions if there are any.
Thank you very much, Dr. Ranjan. Excellent talk. Very crisp regarding the guidelines of APS in pregnancy. So we have a few questions in the chat box. Yeah, so whether arterial or venous thrombo, you made it very clear that high intensity usually doesn't help. But should the target INR be lower in venous? That is one question.
Okay, so I'll answer one by one. So target INR as per guidelines is recommended to be between 2 and 3, whether it is venous or arterial. We need not keep a low INR target for any of the thrombotic events.
Why do you think DOACs don't perform in APS?
So, ma'am, DOACs as such, it is a clinical observation. They had never tried, they would have never tried had they not known that, this is going to affect this way, but this is going to have this kind of effect. But what I feel is that probably it's a clinical observation, which is surprising for so many people. They work so well in cardiac diseases, but then they don't perform well here. So
There is no
exactly.
evidence regarding pharmacokinetics or pharmacodynamics that could be responsible for this.
Possible, ma'am. At least I am not aware of any such cause. There may be one, yes.
In case of secondary causes like with malignancy, etc., there can we use DOACs? So there also it's only warfarin.
So, ma'am, again, the first line is still vitamin K antagonist, because once you have another risk factor, rather it is the reason to continue vitamin K antagonist rather than going to DOACs. DOACs are going to be unsuccessful and miserably unsuccessful there rather than being successful.
A lot of compliments for you also on the way.
Thank you, ma'am.
Yeah. In patients with obstructed APS with LAC positive, would you recommend a lifelong prophylaxis?
So it is obstetric APS. Patient has never had a thrombosis. Now,
Right.
so for obstetric purpose, I would keep the patient on aspirin alone. If patient has had a pregnancy loss, I would give the patient heparin. But as soon as the patient has completed the pregnancy, I would take the patient off as heparin. And since she is LAC positive, which is a high risk profile, I would keep the patient on aspirin lifelong.
There are some patients who have recurrent pregnancy losses and they are ANA positive, but
Yes.
APS antibodies all negative.
Yes.
So there the obstetrician often insists that you should give heparin. We say, okay, only aspirin. So what is your thought on that?
So, ma'am, if patient is only ANA positive, if you talk about the evidence, I have purposefully not put that slide, but there are studies which say that ANA being positive is a poor prognostic factor. But I feel giving the medicine to so many ladies who may be ANA positive would be rather more detrimental rather than being beneficial. So patient being only ANA positive, not having anything else, I would not give anything.
If a patient with previous pregnancy morbidity and only LAC positivity, no thrombosis history, no underlying lupus, would you prefer management what would you prefer as a management in a second pregnancy?
Ma'am, could you please come again on this question?
Yeah, so a patient who has a pregnancy loss, one pregnancy loss and LAC positive, but no history of thrombosis and no other connective tissue disease. So what would be your advice during the second pregnancy?
So my question would be, when was the pregnancy loss? Was it in the first trimester, less than 10 weeks? You need not do anything. Just reassure the patient and send back. But if the pregnancy loss was in second trimester, third trimester, and patient is LAC positive, I would give this patient next time at least aspirin.
What about prophylactic heparin?
So, ma'am, then it comes to individual's choice, patient's preferences, and how desperate the patient is. There are patients who have given heparin. There are patients who have not given, who wanted to, try. And these are the things. But yes, we may give heparin also here. The house would be divided, I'm sure.
Any role of mycophenolate mofetil in APS with recurrent events, like in between the two pregnancies, in spite of VKA plus aspirin plus maybe HCQ, etc.
So I would again like to tell one thing to everybody. Unlike many other disorders where we have thrombosis, thrombosis is an outcome of inflammation, vasculitis. Here we don't have vasculitis. Here we have only vasculopathy at the most. So here there is no inflammation. Since there is no inflammation, there is no role of any immunosuppression. And that is why we see that steroids have failed. We have seen that all kinds of immunosuppressants like cyclophosphamide, mycophenolate, rituximab are all second line. So if we are giving mycophenolate just for vascular thrombosis, it is absolutely of no use.
Patients with catastrophic APS often have severe thrombocytopenia and coagulation issues. How do you plan heparin in such patients?
So it's a double-edged sword, and there is no guideline, and it's basically hit and trial. At times we do have this, we basically, you need to replenish the platelets, you need to replenish the coagulation factors and keep monitoring. That's the only way.
Yeah, I think if we have a hematologist available at the
Yes.
center, we should co-manage.
Yeah, true, ma'am, true.
Dr. Varsha, you have a question? Yeah.
Yeah.
anybody-
Hi, Dr. Ranjan. Excellent.
Yes, Dr. Varsha, yes. Thank you, Dr. Varsha. Bataiye, please.
So I just wanted to ask if there's only exclusive cardiac involvement, what would you do? Like if there are vegetations or heart wall dysfunction, nothing else.
So again, no guidelines, based on whatever little evidence we have. Patient has got a cardiac agitation, which is small. Patient is not very symptomatic. Give only aspirin. Patient is symptomatic, we can anticoagulate. We should anticoagulate the patient and then surgical intervention. If patient has a vegetation which can embolize, first is to remove that and then anticoagulate the patient to prevent further vegetations.
Okay, thank you.
Any other questions? Because a lot of faculty and students today. Any student would like to ask? Please open up and ask. Yeah. Okay. Aditi, you want to ask something? Okay.
Oh, ma'am. Thank you, sir.
No? Okay. Okay. Thank you so much, Dr. Ranjan. It was an
Thank you, ma'am. Thank you
excellent
for
talk.
giving me
We
the
really
opportunity.
enjoyed.
Yes.
Thank you for sparing your time on Sunday. We had a lot of very good attendance today. So thank you everyone for joining us. See you all soon. Take care. Yeah.
Thank you, ma'am.
Have a happy day today. Bye-bye.